thanks everyone for sticking around, and for those of you who might have joined up in the last few minutes. This next section of the presentation is really looking at small and large intestinal surgery. And again, we're really going to focus on, I guess, tips and tricks and things to try and make your life easier in your practice, and to hopefully try and optimize the outcomes in your patients. So what are we doing? What's the plan with this lecture? We're going to look at some surgical principles, and we're going to look at things like wound healing. We're going to look at some decision making with sutures and types of suture patterns, things like that. We're going to look at some surgical procedures, specifically enterotomy and resection and anastomosis. We're going to have a chat about why large intestinal surgery might be different than small, and then we're going to have a chat about some complications as well. So we'll get stuck in. I've got a few slides to get through in this one. Now, if you guys want me to slow down, or if you want me to repeat something, please sing out and let the guys know. So surgical principles, things we want to think about, again, perioperative management, things to try and do and things to assess before you actually get into the surgery. We're going to have a chat about perioperative antimicrobials. I think it's important that we use these things appropriately. As we talked about, we're going to look at intestinal healing. That's going to lead into decisions on sutures and needle selection and suture patterns. We're going to have a look at some of our options for augmenting intestinal surgery. And then we're going to have a chat about how we might assess intestinal viability as well. So again, we touched on this in the first lecture, and we're not going to go into a huge amount of detail right now, but this perioperative management and this cardiovascular assessment, this patient assessment first, is really critical before we do any surgery. It's no point taking an animal, giving an anaesthetic if it's not going to get through that procedure because we've cut some corners, or we're trying to rush things. So a very thorough cardiovascular assessment is important. I think almost always hematology and biochemistry is appropriate when we're giving an anaesthetic. It's a routine in our practice to do a routine blood panel, especially if they haven't had it done in a few months, and especially if the animals are older. It's important to look at electrolytes and blood gas, and to consider fluid therapy, and really important is that if you detect changes, so if there's blood gas changes or electrolyte abnormalities or fluid deficits, you need to correct these things before you administer the anaesthetic. Now, getting straight into the perioperative antimicrobials. When we look at intestinal surgery, there's different classifications for different surgeries, and intestinal surgery is classified as being clean contaminated. And that is associated overall with an infection rate of somewhere around about 3.5% to 5%. Okay, and so that's not an insignificant number. And perioperative antimicrobials are actually indicated in clean contaminated surgeries in order to try and prevent the risk of developing a post-operative infection. Okay, now wound infections occur because of a number of different reasons, and there's a whole bunch of factors at play. And one of the things that is important to consider is the interplay between not only the pathogen or the bug that's in there, but it also has to do, for a wound infection to actually establish itself, there has to be deficits or problems with the wound environment, and also host defense mechanisms. And so a wound infection, for it to develop, is an interplay between these three things. Now, there's various steps that we can take along the way to try and improve wound healing or improve the local wound environment, and to bolster the host the host defense mechanisms. And the antimicrobials are really aimed at trying to target specifically the pathogens, and what we're trying to do is reduce the number of pathogenic organisms that might be present at the surgical site to try and prevent that infection. The key considerations when we're using perioperative antimicrobials, there's really three things. The first thing is that we have an antibiotic, and we choose an antibiotic that has an appropriate spectrum of efficacy. And what that means specifically for the intestine, when we look at the small intestine, there's relatively few anaerobes, but there are gram-negative bacteria. So something like a first-generation cephalosporin is appropriate. We commonly use cefalexin. We use it for basically every surgery that we do. It's relatively safe. It's relatively cheap. It has good broad spectrum of activity, especially when we're looking at the small intestine. When we move on to large intestinal surgery, I'm probably going to want to increase the spectrum for that antibiotic, and the reason is that in the large intestine there's increased numbers of anaerobic bacteria, and so we need to increase the spectrum with our cephalosporin, we want to maybe go to a second generation, something like cefazolin, or potentially use something like metronidazole. The second consideration with perioperative antimicrobials is the timing of the first dose. And again, this is general principles relevant to all surgeries, but specifically, when we're looking at intestinal surgery, it's important to make sure that we have got an appropriate drug at the site of the surgery, and it needs to be there from the time the incision is made. Okay, there's no point in giving it afterwards because you can have a larger amount of bacteria and a lot of contamination if we give the antimicrobial after we've made the incision. It's also appropriate that it's there, or it needs to be there at an appropriate concentration. So we need to make sure that there's an adequate amount of it there for it to be efficacious. Okay, the general recommendations for perioperative antimicrobials are that we start them 60 minutes prior to surgery, and they're given every 60 to 90 minutes during the surgery, and then in most cases we give an additional 1 to 2 doses after the surgery. And we do that because there still can be bacterial contamination of the wound until a fibrin seal forms, and that can sometimes take a few hours. The third factor when we're considering perioperative antimicrobials is the timing of discontinuation. And it's really important for it to classify as a perioperative antimicrobial that it's discontinued within 24 hours from the start of the surgery, from the end of the surgery. If you think there is ongoing contamination or ongoing infection, or there has been gross contamination of the surgery, if you spilt a lot of the intestinal contents into the abdomen and you're worried about an ongoing infection, then it is appropriate to use antibiotics into the post-operative period. However, they're no longer perioperative at that point and they become therapeutic antibiotics. Okay, but perioperative antibiotics, a prudent use of perioperative antibiotics is important because we're really trying to minimize the risk for developing resistance. And there's definitely evidence out there that if we use antibiotics routinely into the post-operative period, that we can actually create resistance problems. And in some studies, it's actually been shown that you can actually increase the infection rate. So that's important, in surgery, and that if you do a clean surgery or, something that's clean, contaminated, and you don't have an issue with an ongoing infection, that you shouldn't necessarily be using antibiotics routinely into the post-operative period. The next thing we're going to talk about is intestinal healing. And intestinal healing, like any wound healing, really has the three basic phases of wound healing. There's the inflammatory phase, the proliferative phase, and the maturation phase. And I put this picture at the bottom here to really indicate that there's no absolutely set time points for when one of these phases starts and one of these phases ends. There's a lot of overlap between these different phases. And so at any point in any wound, there's going to be some of that wound that's in the inflammatory phase, there's going to be some of that wound that's in the proliferative phase, and some in the maturation phase. And this is sometimes more of an issue when we're worried about secondary healing. For instance, when we have an open wound and it's healing by second intention, there's definitely going to be various parts of that wound in the different stages. When we're looking at primary healing, which is what we're trying to achieve with a surgical incision that's closed with sutures, those phases are probably going to have less overlapping stages, for instance. Just to review the different phases of wound healing, the inflammatory phase, the key events that we see, really what we're looking at is there's tissue damage and trauma. Ultimately that leads to hemostasis and inflammation, and that inflammation and hemostasis, all those cytokines that are released at that phase at that time, they start to trigger the start of wound healing. The really key thing, when we're looking at cells of the different phases, in the inflammatory phase, initially there's going to be a lot of neutrophils. They're there for the first 1 or 2 days, and then as we get further into the wound healing, they progress and actually get, the numbers change and the proportions change, and we get a larger number of macrophages. The macrophages actually start to eat up the neutrophils that have done the job by cleaning up and debriding the wound and getting rid of the bacteria. And the key events really in the inflammatory phase there that the neutrophils are trying to do, they're trying to debride that wound and they're trying to reduce the amount of contamination that's there. Okay, and this is important when we think about if there's any existing inflammation or infection. Have you got a septic wound? Have you got a septic peritonitis that you're trying to get an intestinal anastomosis to heal in? Because those inflammatory mediators and that contamination around that wound is going to basically prolong the inflammatory phase of the wound healing. Okay, The other thing that's important in this inflammatory phase is that it relates to the lag phase in intestinal healing, and that's where we have a lot of collagenase activity, and we actually